Okay.
All right, for all who join, welcome to the Neurotology Eastern Region Virtual Education Series. Today we're hosting Dr. Bradley Kesser from the University of Virginia, who's going to be talking about aural atresia. Thank you so much for joining us. We're so fortunate to have you.
No, it's my pleasure. Thank you very much for inviting me. I mean, aural atresia is not a very common condition, but I think to arm you with ways of treating these children with aural atresia is important. So I am going to share my screen, of course, and hopefully you'll be able to see these slides. Let's see. There we go. Okay. Everything look okay?
Looks good.
Okay, excellent. So I have just one disclosure. I patented this little ear tube insertion device simulator, and we sold it to NASCO, and I get royalties enough for dinner for me and my wife for a year. So, not for a year, one dinner a night a year for from the royalties. So you're called to see a newborn in the newborn nursery for evaluation of an ear deformity. And so what are the things that you're thinking about on your way? We want to know, what is the size of the ear deformity, the shape, is there microtia, extra appendages, is there an ear canal, is it in just one ear or is it in both? And ears come in lots and lots of different sizes and shapes: cup ear deformities, lop ear deformities, grade 1, 2, 3, microtia, even anotia. So it's important to characterize kind of what you see, and then it's very important from our standpoint as neurotologists to understand what the hearing status is in the ear. So a little child with anotia. We also want to document associated skin pits. You can see a little pit right there, very classic place for a root of the helix epithelial pit, or a skin tag. You see a little skin tag there, also kind of at the root of the helix in the superior aspect of the tragus. And then ear tags are also very important to document. And then, of course, aural atresia can be associated with syndromes. We want to know what syndromes the child may also have. It could have implications for the airway, implications obviously for hearing and for swallowing. So if we were in person, of course, I would go around and ask, what is this syndrome that's associated with aural atresia? And all of you would chime in and say hemifacial microsomia or Goldenhar. And then we move on to this one, and you tell me that it was Treacher-Collins. You can see the concavity of the mid face here and the temporalis area. And you tell me that this, of course, was Down syndrome, typically not associated with aural atresia, but as all of us know who've seen children with Down syndrome, they can be some really narrow, really tight ear canals. And then finally, I would end up on this one. This is a little bit more tricky. You see the skin tag there. There's a little pit right there. So that maybe start thinking about branchial cleft abnormalities. And if you answered branchio-otorenal syndrome and got a urinalysis, you'd be right on the mark. So syndromes associated with aural atresia or ear canal stenosis, ear tags, ear pits are important to document because obviously they have implications for other organ systems: the heart, the swallowing system, the hearing, as well as the kidneys and the lungs. So what's the status of the external auditory canal? Is it open? Is it stenotic? Is it closed? Is it underdeveloped? Is it bilateral versus unilateral? Here's a guy with a grade 2 microtia and complete atresia of the ear canal. This is also a grade 2 microtia, but I can assure you there's no ear canal. You can see the blue drapes getting ready for surgery, so there's no ear canal. It just ends in a blind pit. And we can't rely on the pediatricians to tell us for sure, because I certainly have seen, and you guys have probably also seen, ear canals clear, tympanic membranes intact and benign, and you're looking and looking and looking and can't find an ear canal or can't find an opening. What's the degree of microtia? Here's a grade 1 microtia where there's just all the cartilaginous structures are in place. It's just kind of a small ear. Maybe there's a little bit of a helical deformity there. Grade 2 microtia, not all the cartilaginous structures. So you see there's some compromise in the triangular fossa. Grade 3 microtia is the classic peanut ear where there's really not much development of the cartilage, and then an anotia. Is there a complete atresia of the ear canal, or is there a stenotic ear canal? And that has implications for the presence of cholesteatoma, which we'll talk about in just a little bit. Laterality and then facial nerve function, also very important to document. Many times, well, I wouldn't say many times, but in children with syndromic features like Goldenhar, there can be some subtle facial nerve abnormalities that are important to document. So what is aural atresia? It's simply failure of the ear canal to open. And with failure of the ear canal to open, with this developmental abnormality, there's also variable development of the ossicles and an absent eardrum. Parents are often surprised when I say, you know, there's no eardrum, I have to rebuild the eardrum. And I have to tell them, you know, if there's a complete aural atresia, then the eardrum never developed. If there's stenosis, however, there can be a rudimentary eardrum that may or may not be connected to the ossicular chain. So that's something we can sort out many times with the CT scan. Its prevalence is 1 in 10 to 20,000. Most of them are unilateral, most occur in males, and most occur in the right ear, all of which reasons we do not know. And of course, as you know, it results in a conductive hearing loss. So our first pearl and pitfall as we're going toward the newborn ICU or the newborn nursery to think about a child with an ear deformity, that congenital aural atresia does not always occur in isolation. Think about and identify associated craniofacial abnormalities. And contrarily, just because the auricle appears normal, don't assume the canal is patent and has developed. There is a condition, de Grouchy syndrome, distal 18q deletion syndrome, where there's a normally developed auricle with an absent ear canal. So you got to do the exam and look in, and you got to look at that newborn hearing screening to see if that child passed or failed. So then we come to hearing, and how are we going to assess? And as you all know from many years back, hearing assessment used to be these doting women who had a bullhorn next to this poor unsuspecting newborn baby to look for the startle reaction with the bullhorn. Well, obviously we have much more sophisticated ways to assess hearing in the newborn period. There's the newborn hearing screening, which can be either otoacoustic emissions or an automated ABR test. And then, of course, if there's a canal, we can do otoacoustic emissions and auditory brainstem response testing. As far as the hearing goes, an understanding of the embryology is important. And embryologically, as we all know, the cochlea develops from the otocyst, from the neuroepithelium, whereas the middle ear and the ear canal develop from the branchial apparatus or the branchial system. And so the implications of this duality of embryologic development of the ear is that most children with aural atresia have normal cochlear function. The timing is different and the embryologic onlog is different between the two systems, so that the cochlea and the auditory nerve are usually normally developed, whereas in the branchial apparatus, there's failure of the ear canal to open. And that's, again, a branchial apparatus abnormality. And so we recommend the ABR test within the first 3 to 6 months of birth. Otoacoustic emissions can be done for the normal ear if it's unilateral. A sound field audiogram with visual reinforced audiometry and OAEs in toddlers, and then masked bone conduction thresholds for the atretic ear in toddlers who are cooperative. I do recommend a bone-conducted ABR in the atretic ear in the newborn period to document the status of the inner ear. So hearing evaluation within the first 3 months of life to document the hearing status with both air and bone conduction ABR thresholds. And then the pitfall is don't assume that the contralateral, if it's a unilateral aural atresia, don't assume that the contralateral normal appearing ear hears normally. You got to do the evaluation and make sure that the normally developed ear also hears normally. All right, so we've gotten our conductive hearing loss documented, normal bone conduction thresholds. What's the next step in the management? Do we get a CT right away? Do we put a bone conducting hearing device on? What's the role or the need for amplification in a child with unilateral aural atresia? Should we be putting bone conducting hearing aids on every child with unilateral atresia? And if we do, what type of amplification do we put on? So lots of questions to address, and some of my research is trying to answer some of these questions that we'll address a little bit later in just a little bit. So pearls and pitfalls, there is no need to get a temporal bone CT scan in the newborn period. There's nothing you're going to do about it, and it exposes the infant to the radiation dose of the CT scan. So no CT in the newborn period. In the setting of aural stenosis, so if there's a pinpoint or a stenotic canal, I generally recommend a CT scan a little bit earlier, around the age of 4 to 5, to evaluate for canal cholesteatoma. Otherwise, I generally get the CT scan around the age of 5 or 6 when the family is starting to consider candidacy, or at least starting to consider canal surgery to open the ear canal. Because if we don't open the ear canal until the age of 6 or 7, there's no reason to get the CT scan until the child is 5 or 6. This brings me to an important imaging pearl that Daryl Brackman always emphasized to me. He said, any child with an unexplained conductive hearing loss should have a temporal bone CT scan. That is, if a child has a normal eardrum, a normal ear canal, and no fluid in the middle ear, but has a conductive hearing loss, that child needs a CT scan. And so if we were all together, I would ask you what this anomaly is, and you would correctly answer in bilateral enlarged vestibular aqueducts, which can give you a conductive or a mixed type hearing loss. Other things include occult congenital cholesteatoma that we can't see on our exam, but we can see on the CT scan, or even a neoplastic lesion that has mass effect on the ossicles, like facial nerve schwannoma, Jacobson's nerve schwannoma, or other middle ear neoplasm. A middle ear ossicular abnormality, we used to call these minor malformations, like the single stapes cruce, or congenital otosclerosis, or actually congenital stapes fixation, incus lateral chain fixation, incudostapedial joint disarticulation. So all those, even though medically the ear is healthy, we need to explore any child with an unexplained conductive hearing loss. So this is a child who had a stenotic kind of pit-like canal. We got a CT scan because of the conductive hearing loss, and we saw this opacification here. And so we weren't sure, because we couldn't see into the canal, we didn't know whether this was fluid or soft tissue. So we got the MRI with diffusion weighted imaging, and sure enough, there's a bright signal on the DWI image sequence consistent with a ear canal cholesteatoma. And when we opened the ear, sure enough, there was trapped epithelium in a stenotic canal. So have a low threshold in a child 4 or 5 to go ahead and get the CT scan if you see a pit or a stenotic canal. So what are the options for amplification, and what is the role for amplification in the child with unilateral aural atresia? So the options include observation with monitoring the hearing. And I want to stress, we need to continue to monitor the hearing to make sure that the normally developed ear doesn't decline with time. It's rare, but you want to be on top of it. Preferential seating in class, an individual education program, an IEP, or a 504C plan. Very important to talk about when the child enters the elementary school years, to talk about with the parents so that an IEP or a 504C plan can be put in place for the child. An FM system, conventional amplification, bone conducting technology, which comes in all different shapes and sizes, like a hard band that you see here. There's a soft band. Medal has come up with the Adhere, which is an adhesive, just a piece of tape, medical tape that sits behind the ear, and you snap on the bone conducting oscillator when you put on the device. And then, of course, there are the osseo-integrated bone conducting hearing devices. So FM systems are where the speaker's voice or the teacher's voice is sent wirelessly in real time from the transmitter to the receiver in the better hearing ear. So it's worn in the better hearing ear for children in the classroom. It's non-invasive. It definitely improves the signal to noise ratio, but it comes with some limitations, including it's cumbersome. There's limited applicability outside the classroom setting. Children are not going to wear these FM systems on the playground. But it can be effective in the classroom, so the teacher wears the microphone or the receiver and then the signal goes to the child where it's worn either as an earbud or ear level or maybe at a speaker on the desk. The bone conduction devices on a soft band or a hard band are, again, non-invasive. They are effective. I think all of us would agree that a child with bilateral aural atresia must have, well, must is a strong word, but should at least be offered a bone conducting hearing device. They can be uncomfortable. There is some attenuation of sound due to the scalp and the soft tissue. But for a child with bilateral aural atresia, these can be really miracle devices in terms of their speech and language development. And then we come to the osseo-integrated bone conduction devices. The percutaneous device, including the Baha Connect by Cochlear, there's the most efficient conduction of sound because there's a direct coupling of sound energy through the oscillator to the abutment and into the implant. It does require surgery. It's not a difficult surgery to do. The FDA has not approved these for children under the age of 5. And for children 5 to 10, I will do it in a 2-stage procedure. But in children that are teenagers, 10 to 15 and 10 to 18, I will put a sleeper implant in and do a single stage for the full device. And then if you've done one of these, you've had wound issues and skin issues, and they can be pretty challenging. The Ponto by Oticon is another percutaneous, comes through the skin device. The transcutaneous devices include the Baha Attract, so there's no post, so nothing is coming through the skin, so that obviates any of the wound issues that we had in the percutaneous devices. But it requires surgery and there is less efficient conduction of sound. There's a fall off in the high frequencies so that sound energy still has to be conducted through the scalp and the soft tissue. And so there's a fall off in the efficiency of sound conduction. The bone bridge is a more efficient conduction because the active oscillating part is now directly against the bone. So the floating mass transducer or the bone vibrator, the bone oscillator, sits in the mastoid bone. You still have an internal receiver stimulator, and then you wear the microphone and transmitter on the outside. There's no post, no wound issues. Probably more efficient conduction of sound does require a little bit more extensive surgery to drill the mastoid and put the bell in and secure it to the mastoid cortex. The cochlear osseo works on the same implant platform as does the Baha Attract and the Baha Connect. Rather than attaching the abutment or the magnet to the implant, now we're attaching the mass transducer. Now we're attaching the active transducer. So this is the active part. You still have a microphone and transmitter that's worn on the outside. The sound energy goes through the induction coil to the receiver stimulator that then stimulates the active part directly connected to the implant that's integrated into the bone. The Vibrant Sound Bridge is not approved for aural atresia by the FDA in this country, but it has been used with success in Europe. There's a floating mass transducer that's placed at the incutostapedial joint or potentially even placed at the round window. I find in surgery, the round window is very difficult to access because the facial nerve comes around really tight. And it can be very difficult to expose the round window in aural atresia surgery. But there's a microphone and transmitter worn on the outside that then sends the sound energy or the electromagnetic energy to the through the induction coil to the receiver stimulator that then stimulates the floating mass transducer. And so that then vibrates the ossicles. You still have to expose the ossicular chain. You have to free the ossicular chain, and you have to attach or clip the FMT onto the ossicular chain. So pearls and pitfalls of the osseo-integrated devices: the post abutments, the Connect, the Ponto deliver better sound fidelity at the cost of skin issues in some patients. The transcutaneous processors, the Attract and the Ossea, may not stay on an active child as well, not quite as efficient bone conduction, but I think the Ossea is quite good, and I've just done one bone bridge in an adult, and that patient gains significant benefit and likes the bone bridge. So I get back to that question, should we be putting bone conductors on all children with unilateral aural atresia? The pros and cons: it does stimulate the atretic ear, the cochlear, and the central auditory pathways. It does support speech and language development. They do get head shadow. In other words, they can hear from the atretic ear side. There is a cost, around $5,000 for the surgery, and the actually $5,000 for the equipment, and then the surgery can be another $5,000. There is some comfort and compliance. There's some cosmesis issues. The bone conducting devices do not aid in sound localization. There may be marginal benefit in noise, and whether there's a perceived benefit overall, I still feel that remains to be answered. And so what is the binaural advantage? And do children get the binaural advantage if they have a normal hearing ear in one ear and wearing a bone conducting device on an atretic ear? Well, you know that hearing and noise and sound localization are the two functions that are mediated by binaural processing or binaural hearing. And so do bone conducting hearing devices provide sound localization and hearing and noise? And here are a couple of studies that looked at that. Patients with unilateral conductive hearing loss showed no difference in sound localization in the aided versus unaided conditions. In children with unilateral conductive hearing loss, a hearing aid helped somewhat with hearing and noise, but did not improve sound localization. No improvement in objective measures, sound localization and hearing and noise, but some subjective improvement. So I think taken all together, we have to counsel our families that they really are not going to help with sound localization. They may offer a little bit of benefit with hearing and noise, but they can be very difficult to place on a child. And so what if you do nothing? And we looked at that question a few years ago and wanted to know, of the children in unilateral aural atresia, do they have the same grade repetition rate or need to repeat a grade as children in the unilateral sensory neural hearing loss group? And we used the same metrics that Bess and Tharp about 30 years ago used in their studies that showed that children with unilateral sensory neural hearing loss, a subset of those children, did show significant disability in elementary school. They were at higher risk for repeating a grade, higher risk for behavioral problems. But in our study, our unilateral aural atresia group, no child needed to repeat a grade. They used resources about 2/3 of the time, or I should say 2/3 of the patients used a resource, and I'll tell you what the resources were in just a second. They didn't have behavioral problems. And so if you statistically compared our atresia group with the Bess and Tharp unilateral sensory neural hearing group, there was a statistically significant difference in grade retention, whether they needed to repeat a grade. The other interesting finding of this study is that if you looked at our sensory neural hearing loss group from 2015 or so, and the Bess and Tharp group from 1985, there was no difference in grade retention. So even though we're 25, 30 years down the road from the Bess and Tharp studies, I don't know that we're making a lot of headway in these children with unilateral sensory neural hearing loss, at least in terms of grade retention. So here are the resources that were used. 65% used any resource, but very few, only 12.5% used any kind of amplification. This is for the atresia group. Interestingly, only about a quarter to a third of the sensory neural hearing loss group, this is unilateral sensory neural hearing loss, used a hearing aid as well. Speech therapy, FM system was fairly popular. IEP was important. So I always tell folks, don't forget to remind parents to put in place IEPs or 504C plans for your child. At least they can sit near the front of the class. When we looked at use of resources, our atresia kids used resources much more than the Bess and Tharp group, but our atresia kids did not use resources any greater or any less than our own sensory neural hearing loss group. Our own sensory neural hearing loss group used resources to a much greater effect or much greater prevalence than those children in the Bess and Tharp group. So we're using resources, but those unilateral sensory neural hearing loss kids still face challenges. So we get back to the pros and cons, and I'll go back to the cost. Again, a must in children with bilateral aural atresia. And if we estimate the prevalence of atresia at 1 in 10 to 20,000, and there are 300 million people, 330 million people in the United States, I estimated that the cost would be about $75 million to outfit every child with unilateral aural atresia with a bone conducting hearing device. So here's my approach. Here's where the rubber meets the road. I never discourage a family with a child with unilateral hearing loss to trial a bone conducting hearing device. I support and encourage the family's desire to trial. I strongly suggest or strongly recommend we continue to monitor the hearing and academic progress, support the child's speech and language development and academic progress. Again, the 504C plan. The earlier the trial, the better the adoption by the child. If you can put one on at the age of 6 months, they don't have the motor skills to knock it off, and so they will better more effectively adopt the bone conducting hearing device. Whether it provides them any benefit, that's got to be a longitudinal study to look at these children over time. And so I tell parents, we've got a lot of battles to face as parents. Having your child wear a bone conducting hearing device for 8 or 10 hours a day is not one of the battles that we have to face. So finally, we come to atresia repair surgery. What role does that have in these children with unilateral or bilateral aural atresia? And it's important to know, first off, that not all children with aural atresia are candidates for canal surgery. And it's through both the audiometric and radiologic evaluation that we can assess their candidacy for aural atresia surgery. And having done this for many years, I will admit I cherry pick these children. You know, if there's something not quite right with the ossicles or the middle ear volume is small, I'll warn parents, your child may get a good early result, but the long-term result may not be as good. So who's a candidate for atresia surgery? That's based on age, audiometry, anatomy, and cooperability, which we'll talk about. And I think the ideal age to operate is about 6 to 7 years old. Why wait until the child is 6 to 7? There's a radiation dose for the CT scan. So if they're older and bigger, there's less total body dose of radiation to the child. Change in the anatomy as the child grows. The middle ear and the mastoid volume increases as the child gets older, and the eustachian tube matures. As we all know, most children outgrow their ear infections. So I don't want to do a great operation only to have fluid in the middle ear compromise their hearing. So eustachian tube maturity is important. Accurate audiometry, air and bone conduction thresholds. A 3-year-old cannot sit with ear-specific air and bone conduction threshold behavioral audiometric testing. Just doesn't happen. When they get older, they can then sit for the audiometric testing. I think they may heal a little bit better. There's certainly issues of cooperation in the office that these older children just get it. They're more cooperative. You have to take the packing out, you have to clean the ear, and they just understand the evidence. They understand the situation. And there's no evidence to suggest that waiting is harmful. Air and bone conduction thresholds are important. This is a child with bilateral aural atresia. You can see the air conduction thresholds reside around the 60, 65, 70 mark, where bone conduction thresholds, which is done through the SAL technique, the sensory neural acuity level technique, so we can get ear-specific bone conduction thresholds in a child with bilateral aural atresia. And of course, I use the Jarsdorfer score. Everybody knows the Jarsdorfer scale. You get a point for every anatomic structure that looks favorable. And of course, the stapes bone gets 2 points. What we found is that the middle ear volume, or the volume of the middle ear space, is an important predictor of not only early postoperative hearing outcomes, but also long-term postoperative outcomes. And I'll show you the data in just a sec. So here's a middle ear that we did a segmentation analysis through our PAC system, where we can outline the volume of the middle ear. And through a number of axial cuts, we can get the volume. This volume was about 600 cubic millimeters. And here's a atretic ear 1, where the volume was a little bit more than half of that, And you can see how the middle ear volume is a little bit smaller or more constricted. Here's atretic ear 2 with a really tight middle ear volume. So you can see we left out the air cells and we just took the volume of the middle ear space with this segmentation protocol. So if you look at the pure tone average before and after surgery, stratified by atresia volume, before surgery, there's really no difference in the pure tone average in children with small middle ear volumes in red compared to children with large middle ear volumes in blue. After surgery, though, the children with small middle ear volumes had a greater pure tone average, in other words, worse hearing than children with greater middle ear volumes. And the same was true for the speech reception threshold. No difference in pre-op audiometric function or SRT, but after surgery, children with a greater middle ear volume had lower speech reception thresholds. And that cutoff number was about 300, 305 cubic millimeters. So we look at middle ear volume for sure, and we counsel parents on our chances of improving the hearing. Here are a couple of CT scans that are pretty obvious they're not candidates. Here, the tegmen is too low. If you try to drill into the middle ear, you're going to be in the middle fossa. Same with this one. There's no air in the middle ear. The tegmen is really low. You can't get it. You can't access the middle ear. Not a candidate. Here's a patient that looks pretty good. You can follow the tegmen in, but oh man, look at that facial nerve. Comes right across the oval window here and would be right in your drill path trying to access the malleus incus complex. Again, not a good candidate. So with surgery, some general considerations. The canal surgery is done after the rib graft. If the family has chosen the autologous rib graft microtia repair, we do the canal surgery after the rib graft. But if the family has chosen MedPOR or SUPOR microtia repair, the canal surgery goes before, which is actually kind of nice because you don't have the auricle to worry about. You just make a small postauricular incision. This is about where the canal is going to go based on my palpation of the mastoid tip and the zygomatic root. Facial nerve monitoring is a must, and the arm and leg must be accessible for the skin graft. So there's several steps in the operation. I want to check, make sure I'm not going over time. Good. The approach, drilling the canal and freeing the ossicular chain so that the ossicles are liberated and can vibrate freely in space, harvesting the split thickness skin graft, the eardrum graft, placing the skin graft, and aligning the auricle and doing the meatoplasty. It's a good 4 to 5 hour operation. It's technically challenging. You just have to take your time and do it stepwise, step by step. All right, so this is a child with grade 2 microtia. You'll have to trust me, there is absolutely no ear canal. So complete atresia of the ear canal. We make a standard postauricular incision. We harvest temporalis fascia like we would for a chronic ear. We scrape the fascia out on the Teflon block to prepare it for eardrum grafting later on. We make our periosteal cuts along the linea temporalis and then anteriorly along the glenoid fossa down to the mastoid tip. And so I've elevated the mastoid periosteum posteriorly and reflected it in the auricle. Now we're using the narrow elevator to elevate the periosteum anteriorly to identify the glenoid fossa. So I'm looking for the posterior rim of the glenoid fossa. This is a right ear in the surgical position. So the mastoid tip is right here. The glenoid fossa is right here. You can see it dive down, almost looks like an ear canal. And the root of the zygoma is up here. So with those bony landmarks, we know we're going to be drilling in the right place. And there's maybe a little dimple here where the ear canal tried to form. So here are the bony landmarks for a right ear. Root of the zygoma, the glenoid fossa up here, and the mastoid tip down here. And here's that periosteal flap that's been reflected posteriorly. Drilling the canal. The key to drilling the canal is finding the tegmen and following the tegmen into the middle ear space. And it's not the mesotympanum that you're looking for, it's the epitympanum. So the ear canal is centered over the epitympanum. In a normally developed ear, remember, the ear canal is centered at the mesotympanum. But here we've got to find the tegmen and follow the tegmen to the epitympanum because that's where we'll identify the ossicular chain. So here's the tegmen, here's the drill path to identify the big epitympanic airspace, and then we start drilling down the atretic plate, which is right here, to liberate the ossicular chain. So I start with a 5mm cutting drill burr. Again, it's a right ear, and I'm staying just like we would do a mastoidectomy, staying at the anterior glenoid fossa and the superior linea temporalis. And I'm opening the canal and I'm pushing my way superiorly so that I can identify the tegmen. And once I've identified the tegmen, then the drilling goes more medially. But it's critical to thin the glenoid fossa. See, it's not even that thin here, but I'm going to thin it and find the tegmen. All right, so now I've identified the tegmen up here. You can see there are no air cells. It kind of has that bluish hue to it. And now I'm down along the atretic plate, and there are air cells here. So I'm drilling in those air cells, staying superior or superiorly to get into the epitympanum. It's not often that the atretic plate goes all the way up to the tegmen. So there are usually air cells here that you can find and follow those air cells. So now I'm using a dental excavator to pick away or fracture away the small pieces of bone that are preventing my accessing the epitympanum. Here we've got a nice big airspace here. And in fact, that might be an ossicle right there. And I'm palpating it. It does seem to be an ossicle. All right, so now I've drilled all the atretic plate, and drilling down in this posterior inferior quadrant, the facial nerve can come up on you very, very fast. And so I always take care to kind of drill a little bit and look, drill a little bit and look, because you can get a very tight second genu. So here's the tympanic facial nerve, comes around right here, and it's very lateral and anterior near where I'm drilling this last bit of the atretic plate, and that's the facial nerve. So beware. So here as a still image, we've opened into the epitympanum. This is a left ear. You can see the epitympanic space, and opening it up a little bit more, we can see the fused malleus incus complex right there. Once we've drilled all the atretic plate, there are final ligamentous attachments between the neck of the malleus right here and the atretic plate right there. I'm using a 59 beaver blade to very carefully and very slowly and very deliberately cut through those ligamentous attachments. And if you've drilled that ledge of bone at the atretic plate well, that whole ledge of bone sometimes can come out. And you can see that I'm delivering that ledge of bone. And now we've got a nice big space of middle ear to minimize the risk of ossicular refixation. The skin graft I generally take from the non-hair-bearing arm, the upper arm. I use the 5-inch blade with 2-inch cutting width at 0.006 inches thick. It is very, very thin, 5 to 6 centimeters in length. And so I use a standard Zimmer dermatome, the upper arm. If the arm is too skinny for the 2-inch guard, I'll take it from the lateral thigh. And then I prepare it by tapering the edges, cutting these edges to a taper, and then making 5 notches. And those notches will align over the temporalis fascia graft. The temporalis fascia graft is next placed down into the medial canal and draped over the ossicular mass, over the fused malleus incus complex. So if you can appreciate, it's almost like you're seeing the malleus incus in relief as the fascia graft really drapes over that malleus incus complex. And I use the Rosen needle to tuck that fascia graft around the edges of the ossicular chain. So here's a quick video. The fascia graft goes in. That anterior edge of the fascia graft kind of comes down, drapes down onto the anterior canal wall. And now I'm just delivering it down into the medial canal. Here's the malleus incus complex right here that you can see through the fascia graft. The fascia graft is draped nicely up onto the bony canal wall in all dimensions. And as it rehydrates, it thins, and I'm going to use the Rosa needle to really just tuck it down around the malleus incus complex and draped on the malleus incus complex. Split thickness skin graft is hard. It's really hard. There are no two ways about it. It takes time, it takes practice. You've got to deliver the graft down into the medial canal and align those tabs over the fascia graft and make sure that the tabs are covering the entire fascia graft. You want the entire thing covered by the epithelium of the skin graft. And so here's the skin graft going in. Here's tab number 1. It's going to go anteriorly up here on the anterior canal wall. And I won't play the entire video, but it just gives you an idea of getting these tabs down. They curl under, and you have to unfurl them and place them down onto the fascia graft. Make sure that edge comes out right in there. Here comes tab number 2. And it just kind of snugs up against tab number 1, and you just kind of make your way around the clock to tab number 5. Sometimes there's tab number 5 is redundant, and I'll trim it back. But you get the idea. I use a ball probe, not a Rosa needle, but a ball probe. It's a really nice instrument for placing the skin graft. All right, after the skin graft goes in, I place a silastic disc, 0.04 inch silastic disc, down over the skin graft and the fascia graft to recreate that anterior tympanomeatal angle. You can see the skin graft, the edges of the skin graft meet right here. Once the silastic goes in, I'll pack the canal with 3/4 length Pope wicks. So these are 3/4 length. I don't want them sticking out or jutting out above the skin graft. So I cut them to 3/4 length. And once I cut them to 3/4 length, I usually put in about 3 to 5 of these Pope wicks. Once they're standing up in position, I'll use Floxin Odic, and the ofloxacin hydrates the wicks. The wicks expand and will hold the skin graft up against the bony canal where it will take its blood supply. And then we'll fold over the lateral portion of the skin graft and deliver that through the meatus. Here's the meatoplasty. It's a curvilinear incision, a U-shaped incision starting at the superior aspect of the tragus, extending back into the conchal skin, inferiorly and around to the inferior aspect of the tragus. I've elevated the skin flap off of the underlying cartilage and soft tissue and reflected this anteriorly based conchal skin flap anteriorly forward, and then cored out the underlying cartilage and soft tissue. So now you're looking through the new meatus. And so here I've put the ear back. So now we've folded the ear back. We put a tacking suture in the postauricular incision. You're looking through the meatus. Here's that conchal skin flap that's now dunked down into the canal to become the anterior lateral canal wall. And I'm delivering that lateral split thickness skin graft through the meatus. There are Pope earwicks right there. So we know we're lined up well. It looks good. And I'll just suture the edges of the skin graft to the native skin of the concha with interrupted 5/0 facet-absorbing gut sutures. It only usually takes maybe 3 or 4 sutures to suture it in place. Once I've sutured it in place, we'll put full-length Pope wicks down into the canal, and we'll hydrate those Pope earwicks with floxin so that they expand and again hold that skin graft in place. All right, so here is the meatoplasty in an ear that I've done before med-pore reconstruction. So you see the postauricular incision here, and then I've made a canal incision up here, like a triangle. And so we'll put the eardrum graft in, we'll put the skin graft in, we'll put our packing in, and then suture the skin graft to the native skin, and then suture the postauricular incision closed superiorly and inferiorly. I usually keep the kids in the hospital overnight just for one night for nausea, vomiting, and pain control. I do put them on Keflex for about 5 or 6 days. The dressings come down. The mastoid pressure dressing comes down on post-op day 1. Change the cotton ball with bacitracin, a little bit of sutureline care, keep the ear dry and the arm dry. At the 1-week post-operative visit, I take out the Pope ear wicks and the silastic button, take out any sutures if they're sutures, although sometimes I'll just let them dissolve on their own. I put them on antibiotic ear drops twice a day for a week, check the arm, keep the ear dry. At the 1-month visit, there's a dead skin layer that forms over that skin graft, and I just carefully peel that dead skin layer off and remove it. Just like a snake would shed its skin, I just peel that dead skin layer off. Again, checking the arm, and that's when I do our first post-operative audiogram. So we looked at 116 ears a few years ago. Most of the ears were Jarsdorfer grade 7 and 8, asking the question, does the Jarsdorfer grade truly have any predictive ability in terms of their post-operative hearing outcomes? And sure enough, if the Jarsdorfer score were 6 or below, there was only about a 45% chance that they would get a normal hearing ear. But if the Jarsdorfer score were 7, 8, or 9, they had an 85 to 90% chance of getting normal or near normal hearing with atresia surgery. So the Jarsdorfer score really is helpful in its ability to predict postoperative hearing outcomes. What about long-term hearing outcomes? Our former fellow Ted Embry and I published a study a couple years ago looking at 138 ears greater than 1 year out. The mean was 11.1 years with a range of 4.8 to 6.67 months. So that's months, not years. 54 left, 84 right, 64 females and 64 males. The median Jarsdorfer score was 8 with a range of 6 to 9. The last postoperative audiogram was 4.4, an average of 4.4 years after surgery. So the mean preoperative air conduction pure tone average was 59.6. The mean first postoperative air conduction audiogram was 29.1. So that's a gain of 30 decibels. The mean last postoperative audiogram, again, a mean of 4.4 years after surgery, was 37.3. So the final gain was 22 decibels, which indicates a loss of 8.2 decibels when you compare the first postoperative audiogram to the last postoperative audiogram. So there is some decline of hearing in some patients, not in every patient, and that average is about 8.2 decibels. And here's a kind of a spaghetti graph showing all of the data. The pure tone average pre-op is along here, the y-axis. Time is along the x-axis. You can see how the hearing, the pure tone average comes down nicely at the first post-op audiogram, and then there's a wide variability in time. Middle ear volume is predictive. Of those who had the best long-term hearing outcomes, their middle ear volume was much greater than those who had the worst audiometric performance group, or the worst audiometric performance group. Complications. Ear canal stenosis remains the most common complication, and I try to head that off at the pass. I will inject the meatal skin with Kenalog before we wake up the child. I'll inject it in the office. Sometimes I'll have parents put in a foam earplug at night for the first 3 to 6 months after surgery. Again, here's the injection of steroid, the foam earplug at night coated in a water-soluble lubricant. All right, so what about canal surgery versus the osseointegrated bone conduction devices? I'll be the first to tell you that bone conduction hearing devices blow canalplasty out of the water when it comes to hearing outcomes. Canalplasty is hard, higher rate of complications, variable hearing outcomes. Do they locate sound in space? Some preliminary data that we've done shows that they do early in the post-op period, but not as well as 2 normal hearing ears. With bone conduction hearing, the hearing is excellent. The hearing is predictable. Some cosmetic issues, they don't get sound localization, maybe a little bit of benefit in noise. This is a study that looked at the 2 techniques, 20 patients in each. The hearing gain 47 dB at 6 months and 40 dB at 12 months in the atresia group. And what they found was that aided canal surgery results were comparable to BAHA. So even though we don't hit a home run in every child, and every child doesn't get a home run long term, a hearing aid in the new ear canal can be very effective in rehabilitating their hearing. Rich Gergel and Nataraja did a nice study almost a decade ago now that showed less hearing gain. Look at the numbers of pure tone average less than 30, only 60% in the Canalplasty, 96% in the bone conducting device. I admit they do great, but I think they also have some limitations. So as we kind of wind up the talk, options for hearing rehabilitation, we talked about preferential seating, the 504C plan, the FM system, conventional hearing aid in a well-formed auricle. Bone conducting technology is certainly an option, and canal surgery. I think for us as a specialty and as a subspecialty, it's important to identify the subset of children at risk. Who is at risk for poor speech and language development, poor scholastic achievement in school? Does laterality of hearing loss have anything to do with it? Is there a right ear advantage? That is, the right ear projects to the left cerebrum, the left language center. Do right ear children, the children with normal hearing right ears and aural atresia in the left, do better than children the opposite? That does not seem to be the case. We need to optimize and follow long-term hearing outcomes and maybe put a hearing aid on a child who's had canal surgery. One final thought is fatigue. These children who have hearing loss are tired. Parents report to me they just want to come home after school and have quiet time. And we looked at fatigue as a covariate in hearing loss. And what we found in 2 recently published studies was that children with bilateral hearing loss have greater levels of fatigue than children with unilateral hearing loss, and that children with unilateral sensory neural hearing loss have greater levels of fatigue than children with unilateral conductive hearing loss, and they all have greater levels of fatigue than control children. So I think mentioning this to parents and making sure children get a good night's sleep and take a nap in the afternoon is important. So in conclusion, every child is different. It's important to optimize resources, preferential seating, et cetera, et cetera. The role of surgery is still being played out. Important to have longitudinal follow-up, monitor their hearing and the academic progress. It's important for us as neurotologists to know all the options for hearing rehabilitation in children with unilateral and bilateral aural atresia. Bone conducting technology is a must in children with bilateral atresia. The benefits, I think, are still unclear in unilateral atresia. You will hear people who are very dogmatic. You've got to put a bone conducting hearing device on your child with unilateral atresia. I'm not so dogmatic about it. Surgery is technically difficult. Patient selection is critical. Don't feel bad about cherry picking these. It's perfectly fine. Meticulous technique is required at each stage of the operation. Make sure children get the rest that they need. Early detection of hearing loss is important. A trial of early intervention. There's no question a 6-month-old is going to take to a bone conductor a lot better than a 3-year-old. Intervention may help the child meet their potential and monitor the hearing and academic progress, set the child up for success. And so with that, I will close it down and stop sharing. And I thank you all very much for joining me on this journey, and I'll be happy to answer any questions.
Thank you, Dr. Kesser. That was just an awesome talk. So comprehensive and balanced.
Thanks, Mel. Thank you very much.
I've got some questions, but I'll open it up for anybody else who might have something.
I've got one, Dr. Kesser.
Yes, sir, Dan.
I was wondering if you might comment a little bit, just kind of for the group, about the sort of balance between yourself and the microtia surgeons and that relationship and sort of the interplay, the dialogue that may happen there, and just how it factors into kind of your decision making.
Yeah, that's a great question. And there has to be dialogue between the reconstructive surgeon and the athletics and the otologist, neurotologist. And that dialogue is about timing of surgery. So we talk about, doing the canal surgery before the med-pore reconstruction, and we talk about doing the canal surgery after the rib graft. If we do the canal surgery before rib graft, we have violated that pristine area that the rib graft surgeons need to build their pocket for the reconstructed auricle for the rib graft. And so that conversation is important because the med-pore surgeons are doing the med-pore younger and younger. They'll do them at 3 years of age. And I will not do a canal surgery at the age of 3. I really feel it's important to wait until the child is 5 or 6. And so we give the parents the option. You can do the med-pore, but that takes you out of candidacy for the canal surgery. Or you can wait and we can get a CT scan. And if you're not a candidate for the canal surgery, then you can have med-pore, at 4 or 5, because I really don't like to get the CT scan at the age of 3 either. And if you are a candidate then and you want to proceed with the canal surgery, then we can do your canal surgery at 5 or 6, and you can go and have the med-pore surgery. So there definitely is a dialogue, whether it's a phone call or an email or a letter. That conversation does need to take place. And not only with canal surgery, this is another point. If we're going to do BAHA, we've got to make sure that the BAHA is placed far enough back so that the med-pore or the rib graft surgeon has enough room to do their reconstructive technique. So I almost always exaggerate and tell the parents, I'm going to put the bone conductor pretty far back because one day you may want a microtia repair, and I don't want this to interfere with future surgery that your child may have. That's an important point. I didn't realize that TM is both Ted Meyer and Ted McCracken.
That's why I have a fish as my namesake.
It's good to see you, Dr. Meyer. Hope you're well.
Good to see you. Thanks for doing this.
Oh, my pleasure. And Teddy, if you're on
Fortunately,
as well.
different middle initials.
I'm sorry?
I said no, fortunately, middle initials.
Got it. Something about middle initial.
2 quick questions, Dr. Kesser. One, if you have significant exposure of mastoid air cells when you have kind of completed the canalplasty, do you alter your reconstruction in any way?
Yeah, I do pack the mastoid air cells with pieces of autologous temporalis muscle. So I'll just harvest a little bit of muscle and just kind of dumbbell the muscle pieces down into the mastoid air cells. That's a good point. I didn't mention that. I try, you can't not expose air cells. You try to expose as few air cells as possible, stay out of the mastoid antrum, that kind of thing. And so if for the air cells that are exposed, yes, I'll plug it with some temporalis muscle.
Got it. And then in terms of your long-term hearing outcomes, aside from restenosis, what other reasons do you speculate explain the long-term decline in pure tone averages?
Right. So I think there are 2 mechanisms by which children may lose some hearing after surgery. One is lateralization of the eardrum graft. So if that eardrum comes away from the ossicles and doesn't make good contact, there's going to be a widening of the air-bone gap. And that's why I'm really compulsive and really meticulous about tucking that fascia graft down around the ossicular chain so that you're looking at the ossicular chain in relief, as you're looking down into the canal. So, so lateralization is one. The other is refixation of the ossicular chain, either new bone growth during puberty or scar tissue that causes the ossicular chain that we've been so careful to avoid drilling on and freeing and liberating. I think will sometimes there'll be a a bony growth, or there'll be a bony bridge that will refix the chain, and that will cause some decline in the air conduction thresholds. And I've gone in and I've drilled that bony bridge away and restored it. And Dan will tell you, sometimes I'll even put a piece of 0.005 inch, really super thin silastic between the neck of the malleus and the atretic plate to prevent that refixation.
Makes sense.
All right,
Thanks.
sorry, I was getting a call, I think, when I was talking before. Sorry, but thanks, Brad. A really awesome talk. Appreciate it.
Oh, Teddy, my pleasure. Happy to do it. Thanks for sponsoring this. Such a great idea.
It's Mallory's work. It really is. It's awesome.
Oh, Mallory has definitely done a fantastic job. This is a great lecture series, and I'm happy to be a part of it. Thanks for having me.
Thanks again, Dr. Kesser. I think we'll wrap up now.
Sounds good. Thanks, Mallory. Thanks, everyone. Have a good evening.
Take care. Bye.
Bye-bye.